So for everybody out there that's watching today, hi everybody, good morning. Good morning. Thank you. So welcome to our 33rd program of this year. Amazing considering we did 31 all of last year and we still have another 6 to go. But good morning and welcome to this MS Views and News Annual Symposium. And for those that don't know, this is already our 5th annual symposium. So again, I want to thank you all for being here. We have a very good crowd here today and I'm really happy to see all these tables nice and full. And we have a lot of people that are watching this on live stream today and I'm thankful for all of you too. So I'm saying hello and thanks for being here. Before I continue, I want to thank for the opportunity to give to our sponsors and those that gave us education grants to do this program. Because without their assistance, these programs that we do is not possible. So, firstly, I want to thank Genzyme, a Santa Fe company, who's the maker of Aubagio. We want to give them a round of applause and thank them for doing this for us today. We also have Mallinckrodt Pharmaceuticals, also previously known as Questcor Pharmaceuticals. They make the Acthar gel that's used for many of you who have relapse. Teva Neuroscience, the maker of Copaxone, who now switched to that 3-day-a-week formula. It's a 40-milligram formula. So we want to thank them for all their help. Genentech, who's a company that none of you know the medication of yet. They have something in the works, hopefully an emerging therapy, and you'll hear about it today from our speakers. Also, other sponsors are Neuroscience Centers of Florida Foundation, Accorda Therapeutics, Biogen IDEC, Bionis, Pfizer, Infinity Research, and Neuroscience Consultants. Again, let's give them all a round of applause because we cannot do these programs without them. And believe me, they want you to learn. Okay, they are helping us because they really want you to learn more about MS. They want your caregivers knowing about it. So, again, I thank them for all they're doing. So, as we continue, we have, in addition to today's program, we still have another few programs happening over the next few weeks, and then we're going to begin the year anew, and we've already got like the first 9 months set up of where we are doing programs. And we're not only going outside of the state of Florida where we're doing programs now, also in Georgia, Alabama, North and South Carolina, but we plan on reaching the northern latitudes of the United States and getting into Illinois and Ohio and Pittsburgh, Pennsylvania. I forgot that goes with that. And also, we hope to be in Indianapolis as well. That's Indiana for those that don't know. So we're going to be up there soon. Okay, but going forward now, let's get started with this program because we got to get these doctors going and you all don't want to hear me speaking the whole time. So our first speaker today, speaking for 35 minutes, is Brian Steingo. After Brian Steingo, we're going to have Dr. Jack Burks, okay, also for 35 minutes. Then we're going to do 35 minutes of Q&A. During that time, during Q&A, lunch is going to begin being served. After that Q&A, we're going to begin with our next panel, which is a psychologist who's going to speak about the cognitive issues as well as the Neuro-Psych testing that's used for a baseline for cognitive as well as your possible disability claims in the future. And after that person, we're having a Social Security disability attorney who will be speaking about the obvious. And then we'll open up the floor again to questions. And after that person, then we'll have another attorney closing out the day. We're doing caregiver rights. And you'll all be very welcome to hear that program too. So, without any further ado, I want to welcome our first speaker of the day, Dr. Brian Steingo. And you have everything ready to go.
Good morning. And welcome. Thank you, Stuart. Stuart has amazing energy. You can see what someone with MS has potential to do. So having a diagnosis of MS doesn't always mean that life is over. It could mean that it's a new beginning, and you can see what Stuart does. He obviously has a very good neurologist. Stuart, who's your neurologist? So I'm going to start this, as I do most times, with this topic of what I call the land of MS, which is when you have a diagnosis of MS, there's many different aspects that we have to consider. And so I have this land of MS. And you'll see there are many topics to talk about when you have MS. You have to think about each one of these. Every time you go and visit your neurologist or other healthcare practitioners, and decide which topic do we deal with today. So firstly, you'll see the very first item on the top left is the diagnosis of MS, what kind of MS you have. This is something right from the beginning, and this is something that evolves over time. The type of MS that you have could change with time. This is something we're always looking at. And then there's the treatment of MS. There is the treatment of a relapse. And then there is the treatment of the disease itself. These are important aspects of treatment. And then there's ongoing research. Of course, research is crucial. That's the thin little blue arrow I put there because Dr. Burks is going to tell you a lot more about MS research. This is a fascinating area because if you think back, the first medication that we had for MS, beta-seron, was only approved in May 1993. It's only 21 years old. And you now think we have about 11 approved drugs. And we have a few more coming. And you'll see about the amount of research going on. This has been an incredible amount of development that has changed the course of MS for many people. And then in the middle at the bottom there, you'll see the symptom tower. And to all of you, you know why we call that the symptom tower. Because there are many symptoms of MS. And so it's important when you go and see your doctor every time to decide what's our discussion today. Is my disease stable so we don't have to talk about the disease-modifying drug and we can concentrate on the symptoms? Or do we need to change the disease-modifying drug? And then on the right-hand side, a most important part of managing MS. At the end of the day, what we want to do for you is make sure that you have the best quality of life that all of us can achieve together. And so you'll see on the right-hand side, medical support, social support, and self-help. What you do for yourself. And that's the part I'm going to concentrate on, is some of these buildings, some of these aspects on the right-hand side, and then Dr. Burks is going to talk to you a little bit more about what's on the left-hand side of what I've labeled the land of MS. So we'll go ahead now. And with the symptoms of MS, we could talk about many symptoms. We could spend all day talking about the many symptoms of MS. What could we talk about? We could talk about the bladder. We could talk about walking. We could talk about many, many different symptoms that happen and their treatment. But specifically, what we're going to deal with today in brief is the invisible symptoms of MS. And you know they're very important symptoms. That's the ones you can't see. That's the ones you can feel, but no one else can see it, as it describes over there. These are the symptoms that when people look at you, they think you look great. So in fact, the MS Society actually came out with a brochure. It was titled, "But You Look So Good." You've probably all seen it. Because you may look very good, but you don't feel good. You have some invisible symptoms. And guess what the most disabling symptoms are? You're going to hear about this later in Social Security. When people apply for Social Security, what do they apply for? Often don't say, "I can't walk well," because maybe they're using a walker or a wheelchair even. We have many patients who still can work but don't walk well. But if you have severe fatigue, and if you have cognitive impairment and pain, nobody else can feel that except you. It's invisible, yet extremely important. So the first one of these I wanted to touch on was fatigue, which is a lack of physical and or mental energy, and it interferes with your usual activities. So it's fatigue that's interfering with your life in some way. That's the kind of fatigue we're talking about. Now, I don't know if this is showing up very well. Maybe you can see it. There's many fatigue scales. This is one of the fatigue scales that I just put in here. But there's many different fatigue scales. And it asks questions about how does the fatigue impact your life? Does it affect your motivation? Does it affect your ability to exercise? What makes it worse? Does it affect your interactions? So there are questions in the fatigue severity scales about to what extent does the fatigue affect your life. So a very important topic. And we're going to talk about two types of fatigue. Fatigue is of two types, and it's very important for your neurologist to say what kind of fatigue do you have. Primary fatigue or secondary fatigue. So if you say you have fatigue, and I say, I'm going to, excuse me, I'm going to prescribe Provigil, that's not a good approach. I need to say, why are you fatigued? And so we need to look at secondary fatigue. All those conditions are listed over there that could also make you fatigued that I might help. For example, weakness, deconditioning. Basically, those things are saying you're not exercising, you're not moving enough. And there's exercises for everybody, no matter what stage, there's exercises for everybody. You might be sleeping badly or might feel depressed. Bladder problems. Bladder problems keep you up at night. You wake up 4 times at night. You don't sleep well. These things all interact with each other. And medication side effects. You started a new medication, an antidepressant, a medication for your bladder, one of the multiple medications that we might use for MS, and it makes you tired and you're fatigued. And then you could have another medical condition. You might have thyroid disease or some other medical condition that makes you fatigued. So when we evaluate fatigue, we need to see what's causing your fatigue. Is it primary fatigue? Is it the fatigue of MS where there's no other good explanation and we need to treat it? Or is it both? You might have both. The primary fatigue of MS and some other cause. And it's important to find the other cause because we can treat those. If your bladder is keeping you up at night, or you have depression or pain that keeps you up at night, and we treat that, we may help your fatigue considerably. So it's always important with fatigue to find out what the cause is. Is it primary or is it secondary fatigue? And these are some of the medications that we use for fatigue. You're familiar with these. Amantadine has been around a long time. It's a medication that we're uncertain how it works. It was discovered coincidentally. It's used for other conditions, even as an antiviral agent and for Parkinson's disease, but it does help a good number of patients. And then the medications you see listed underneath that are stimulants. Provigil and Nuvigil actually work well. And there was a small study published. Actually, Dr. Ramahan here at the University of Miami was an author of a small study that was published. But insurance companies we have to fight them regularly to get these medications. Even though we know that they work for many people, insurance companies fight us about these drugs. These are stimulant medications that help fatigue. So that's the first very important topic. I mentioned sleep briefly over here. This is obviously a symptom that's invisible to others in a sense, but sleep disturbance is very common in MS. In fact, obstructive sleep apnea occurs even in 20% of MS patients. That's why I put this in here. And it's a high number. 20% of people with MS get obstructive sleep apnea. And there's an acronym, these points over here, you'll see the stop bang, you see that on top there, it says the stop bang questionnaire. And this is an acronym of how you know if someone has sleep apnea. So these are the risk items. Snoring, tired, observed apnea, if your partner actually observes apnea, if you have high blood pressure, if you have a high BMI, your age, older age, would be associated more with the neck circumference. For example, over 16 inches in a female or 17 inches in a male would be associated with a higher risk of sleep apnea, and sex, your gender as well, male sex being associated with a higher incidence. So if you have these things, we should evaluate this too to see if we can help your sleep. If you sleep better, you'll have less fatigue, all tied in together. I now want to touch on the subject of pain and MS. This is invisible to other people. And of course, as many of you know, it's also invisible to some physicians. You remember there was a time when physicians said, well, if you've got pain, you don't have MS. And of course, that's entirely incorrect because you certainly can have pain with MS. And pain has complications of emotional complications about how you react to it. You might grimace. It might restrict how you act, and physical complications about your posture. And there's two kinds of pain in MS. And the first pain you see on top, there's musculoskeletal pain. Pain in the muscles, pain in the joints, muscle spasm, muscle tightness, muscle tenderness, pain in the muscles, pain in the joints. MS does not cause joint disease directly. MS is not a disease of the joints. But because someone may walk abnormally, it might put stress on joints, the hip joint, the knee joint, the back. So you can have joint pains from MS too. And then there's the second group of pain, neuropathic pain. And that is pain directly due to the MS, where some nerve pathway in the brain, or often, most commonly in the spinal cord, is directly affected by the MS and causes pain. And the pain can manifest in a number of different ways. It can be acute. And acute pain means it's a sudden onset. A very sudden pain is an acute pain. Or it can be chronic. It's been there for a long time. Or paroxysmal. That is a pain that comes and goes. And I'll give you some examples of these coming up. And these are some ways, and here's another acronym. You see I like acronyms. The old CART acronym of what do we learn about your pain? How did it start? What's the onset? What's the location? Where is it? What's the duration? How long has it been there for? The character of the pain. What kind of pain? What aggravates it? What relieves it? What makes it better? What makes it worse? And then based on all those things, now we arrive at some way of treating your pain. And this is indicating some causes of musculoskeletal pain with MS. I essentially touched on that. And also headaches. Headaches are often from muscle stiffness. Headaches may occur in MS. Headaches often are not related directly to MS. Remember, MS is more common in females. Migraine headaches are much more common in females. Therefore, we do see migraine headaches in MS. We can see muscle tension headaches. The neuropathic pain has certain characteristics. So nerve pain, if you have these complaints, it often makes us think it's a nerve pain. If it's an electrical pain, a stinging pain, a burning pain, hot or cold sensations, these often make us think of a nerve pain. And the area may be sensitive to touch, and it's often worse at night. And here's some example I listed for you. Trigeminal neuralgia. This is a facial pain, and it's often paroxysmal. I told you about paroxysmal pain is a pain that comes and goes. So trigeminal neuralgia pain can come and go. It can be very sharp and electrical. It's very sensitive to touch. You might just touch it with a wash rag or chewing. These things can all make it worse. This is a form of a neuropathic pain. Lermit's sign. Many of you may know Lermit's sign. You bend your head down and feel sensations through your body. They're tingling, electrical sensations, common with MS. And then the MS hug that many of you know about. Another invisible symptom, you feel a hug, like someone's hugging you, maybe very tightly. It may be uncomfortable, maybe electrical, maybe just like a muscle spasm. These are all invisible symptoms of MS. And how do we treat the pain? Neuropathic pain, there are basically two classes of medication that we use for neuropathic pain, and I've listed them. The first is the anti-seizure medications that you're familiar with. That could be gabapentin, also known as Neurontin, or Lyrica, which works in the same pathway. Tegretol or carbamazepine and related drugs listed there have been around for a long time. They're very effective for pain. These medications have side effects. We have to monitor them carefully. This is part of you being part of the team, saying, I understand about this drug. I need to see my neurologist. I need to do the blood test as recommended. I need to understand the medication. These are seizure medications. You can never stop them abruptly. If you're taking a seizure medication and you stop taking the medication, you have a risk of a seizure. You're not using it for a seizure, although seizures are overall a little more common in people with MS, but that's not the purpose. Over here, the purpose of these medications is to help your neuropathic pain, and if they're not working, or you perceive that they're not working, or you're having side effects, you need to get guidance about coming off the medication gradually and not abruptly, because then you could precipitate a seizure. And the second group we use is antidepressant medications, and you'll see listed over here amitriptyline, which is Elavil, which has been around a long time and still remains an effective medication. And then we have a newer generation of these medications, such as Cymbalta. These medications also are antidepressants, but they're also effective in pain, and they also require some monitoring. They can have other side effects, drowsiness, some bladder problems. All these things require a lot of monitoring. And for musculoskeletal pain, we use anti-inflammatory medications. You can use ibuprofen, you can use Advil. Those don't work for neuropathic pain. They do not work for neuropathic pain. You can use the antidepressants for this kind of pain too, or antispasticity medications such as baclofen or tizanidine if there's a lot of spasms. Botox can help spasticity and spasms. And then, of course, most important is the non-pharmacologic methods. Exercise, physical therapy, massage, biofeedback, all these things are very important. And finally, the very last resort for MS pain is to use opioids. There are some people who have severe pain that do not respond to all the measures I've indicated there, and then you may sometimes have to resort to using opioids. At that time, we would involve somebody else, such as in pain management. I'm going to touch briefly on cognitive dysfunction. You're going to hear more about that later. But cognitive dysfunction can occur in up to 2/3 of people with MS, another invisible symptom, a disabling symptom that causes a lot of people to stop work. And there's no direct correlation between cognitive dysfunction and physical symptoms. You could be walking well, you could be running a marathon, yet your memory is very poor, and it's hard for someone to look at that. They look at you and they say, well, you look great. What are you doing? You look so good, but you have memory problems. You can't function. And a lot of people are disabled. A lot of young patients with MS go on disability because of cognitive problems. And these can be seen from early on. They've looked at studies of people with early MS, and they can already see cognitive problems. I've listed some of the studies, some of the aspects that could be affected, such as memory, forming, retaining, acquiring information, attention and concentration, information processing, executive functions, multitasking, visual spatial functions, verbal problems. People say, I have difficulty finding words. I can't get the words out. And this is this over here. All this information is obtained from the National MS Society. How do we manage cognitive function? It goes like everything else we say about MS. To try and prevent it from getting worse, we try and start treatment of the condition very early on, because there is no effective symptomatic treatment. There is no good drug that I can give you for your memory. There have been medications tried. There's a medication called Aricept, for example. Aricept is a medication that is used for Alzheimer's disease. There are studies with MS, small studies. Some showed benefit, some didn't. I'm not convinced it does very much. Probably doesn't do much for Alzheimer's disease either. There's the trial of a medication called Axona, which is also being used for Alzheimer's disease. So we're trying things, but there's still no effective symptomatic medication. So we could use maybe alternative medications. You can try ginkgo. People try ginkgo, ginseng, all those things. You could try those. So most important is mental stimulation. Keep your mind active. And you're going to hear me say that all the time. Mental and physical activity. Do crossword puzzles. Do Sudoku. Go online. Go on the iPad. Go wherever you can. Do exercise all day long. And then self-help. Do things for yourself. Being organized. Planning ahead. It's one of the biggest problems, and you'll see me mention this again later, is how people get cluttered. They don't do things. Organization is very, very important. It's the most important thing. It relieves you of a lot of burden. If there's constantly things to do and you don't end them or finish them, and you've got a clutter on your desk, it causes a lot of stress. And then physical exercise. How else do you affect your memory? A sense of purpose. Keep doing something. Have something to do. It doesn't have to be winning a Nobel Prize. Whatever you, just something. Some interests, some hobbies, support groups, phone calls, interacting with people. And there is cognitive rehabilitation that neuropsychologists can help you with too. And they'll point to you about the things that you can do to strengthen your memory. Now I'm showing you this very briefly. We're not going to do this. This is the rest of the symptoms. We entered the symptom tower and we spoke about the invisible symptoms, and most of these here are quite visible. Not all of them, but fatigue is mentioned. But these are all the other symptoms that can happen with MS. And there are many, many symptoms. And we could spend an hour talking about all these symptoms. And so I am briefly now talking to you about self-help. I'm saying to you, if you have potentially so many symptoms for MS, we run the risk of what I call polypharmacy. That means you're taking too many medications because you're taking medications for your MS. You're taking medications for your MS symptoms, and you're taking medications for any other conditions, whether it's high blood pressure, diabetes, heart disease, pain, a whole bunch of things. You could be taking, at the end of the day, a whole variety of medications. And so what happens? They can interact. And so we need to know all your medications. Be aware of them. I stress this, when you go to your doctor's office, make a list of your medications and take it with you. Don't write down same. Same is not good. Because same, if I had $1 for every time somebody wrote the same and it was the same, or was different, I'd have a lot of dollars. You need to keep a list wherever you go, a list of your medications and a list of all your supplements. Keep a list with you. It's an easy thing. And every doctor you go, you take the list with you. Wherever you go, have a list. You can have it on the internet, have it wherever you want. Print out a list. It's very important. And these are some of the drugs that you could be on. Look at this list. Look at the list of things you could be on. Something for fatigue. Could you be on something for MS and for fatigue and depression and spasticity and pain in your bladder and constipation and dizziness? And could you be on a bunch of medications? You could be. You could be on 10 medications, and we need to know they interact, especially if we want to prescribe something new. We need to say, what are you on? How do they interact? And I can tell you that not infrequently when someone gives me a list of their medications and I look at them, it's not what I'm giving them that's interacting. It's 2 drugs that they're getting from 2 other people, maybe from their cardiologist and their psychiatrist, that have potential for some interaction. And I say, be aware of this. Call somebody. So it's very important that we know the list of all your medications. And this is very important where you come into this and have an active role in your care. And so these are the factors that contribute to this polypharmacy, that you have many diseases potentially, many different medications, and many medications may work differently in different people, at different ages, different conditions. They may have different effects. And then we need monitoring and follow-up. You might not be following up. There's no doubt. People call and say, I need a refill of my medication, and then I look and say, when did I last see you? Well, 2 years ago. So you need to be part of this team of regular follow-up, adhering to the medications. So now I'm going to talk about self-help. That was my first slide on self-help. And then I evolved into this one, which is really where I'll spend a little more time. And you can look at this, and all the self-help things I try to put together in an acronym. You can think of different acronyms. When I come up sometimes with different things I want to add, I struggle with them because I have to change my acronym. But these are all the things that are important in improving your quality of life. At the end of the day, as I said before, what's this all about? We're all trying to make you feel better. How do you do that? So what do? You manage temperature. You manage heat. And how do you do that? You get a cooling vest. You drink cool liquids. So this is a manageable thing. So I had people say sometimes, I go outdoors, it's too hot, I can't walk from here to there. I say, get a cooling vest. They're not expensive. They're cheap ones. There's expensive ones like everything. But there are affordable cooling vests out there, and keep yourself cool. Keep it in an air-conditioned environment. If you exercise, which heats your body up, keep yourself cool. Put on a cooling vest if you like. But there is a way to adapt to temperature. Now, the first E that you see over there could be exercise, because it's so important, but it's expectations. So your expectations are very important. Every time we start a medication, we must explain to you, and you must understand before you leave the office, what are the expectations? What is the purpose of this drug? What is it going to do? How long is it going to take? Could there be side effects? The expectations are very important. So, for example, you start a new drug on a person, and 6 months later they return and say, it's not working. And I say, and how do you know that? And they say, I don't feel better. And I say, well, okay, what's our expectations? The purpose of this medication was to stop your disease from relapsing and to stop your disease from progressing, and you haven't had a relapse and you haven't progressed, so this drug is working for you. Now let's see why you're not better, and you might say, because I've got aches and pains. And say, okay, that's a different thing. We're going to treat your symptom. So it's very important to evaluate and to know what your expectations are. And adherence. You must take the medications as prescribed. So how often do we see this? Well, the dose of this medication, for example, is twice a day, or 3 times a week, or every day. And someone comes in and says, well, I'm not doing well. And I say, okay, are you taking medication X? And that's usually followed by a silence. What's silence? Silence means, not really. And, well, I thought I'm feeling well, so I don't have to take it every day anymore because I'm feeling good. So now I only take it twice a week. Or I have a drug holiday on the weekends, something like that. You have to adhere. Guess what? If you don't take the medication, it's not going to work. So you must take it as prescribed. And if you don't like it because it's a side effect, then discuss it with your doctor and say, I can't tolerate this medication. If you can't tolerate it, we need to find some way either of making it tolerable or finding an alternative. And mental health, I'm going to talk a little more about that in a minute. Very important topic. Complex, important topic. You'll hear more about later too. And sleep. We've already talked about how important sleep is. And look how all these things interact with each other. Your outlook. And there's no doubt, and it's not me just saying this, there's people who have studied this very well, that if you have a positive outlook and try and dwell on positive things instead of negative things, you definitely will feel better. And your immune system will be under less stress. And there was a book written by someone called Nicholas Hall. It was called Neuro-Psychoimmunology. Neuro-Psychoimmunology, the effects of the psychological aspects on the neurological and immunological systems, how they interact with each other. So these are important things. And fatigue we've addressed. Food, I'm going to talk more about your diet. Relationships, having some relationships and trying to surround yourself with healthy relationships, not toxic ones. You don't want people that put you down. There's something wrong with them. They need help too. You want people that are positive, that understand you, ideally. Someone who understands what you're going through, understands the invisible symptoms. And they should come with you to the neurologist so that it can be explained to them. And this to me is always a warning sign. If someone comes and their support system is poor, I say, and the spouse or caregiver or significant other doesn't come with them, this is not a good sign. They need to come with to learn. And interactions, relationships, interactions with other people. Excuse me. This is this kind of thing, a support group. Going to meetings of this kind. Fantastic. We never had these years ago. And all the other meetings that are put out there by the MS Society, the MS Association, all these other meetings are important to attend and go online. And I can't stress enough to you how important exercise is. And exercise doesn't mean you go to the gym 3 days a week for 2 hours. That's great if you can do that. But how about just sitting in your chair and moving your arms, moving your legs, stretching, whatever you can do. There's booklets on all kinds of exercise. They're on the internet. Some movement. Every single day, your body needs to be moving physically and your mind needs to be moving too. Every day. There's plenty of time. There's time for everybody. And keeping up with the news, and that's not meant to be a plug, but it is. MS Views and News would be a good source. You've all heard of that. Otherwise you wouldn't be here. Vitamin D. Now I could have put vitamin D under food, because it is. But vitamin D is so important in MS that I give it a separate heading there. And smoking. We know that smoking is a risk factor for MS. And I'll do some of these. So talking about the diet a little bit, another one of these topics that I could labor on all day, how important is it to eat properly? And I call it defensive nutrition. Calorie and content control. Not only what you eat, but the amount that you eat. Because you could say, I eat very healthy. I don't eat any fatty stuff. I don't eat meat, for example. I don't eat this or that. But you could eat whatever else you eat. You might eat too much of it. So calorie control and content control, both important items. And sharing portions. There's some of the stuff you all heard before multiple times. Thanks to Stuart, this is the 5th year that he's done it, and the 5th year that I've actually done this. And I talk about these topics every year. I evolve it a little bit. But sharing portions, and who do I say you should share with? First person you should share with is yourself. Because you know, when you go and order most portions, they're huge. Especially if they're cheap. If they're expensive, they give you, there's never enough food, right? If you go to an expensive restaurant, you're never going to get enough. You're going to say, oh, I'm hungry. But if you go to Olive Garden and order some pasta, it's too much. Split it in half. When they bring it, ask them right away to bring you something to take it home in and put it in a little doggy bag or something. And then you've got 2 meals. Take half of it home. You can eat half there. I guarantee if you spread it on your plate and eat slowly, it'll be enough. You've got another meal. So share the portions mostly with yourself, and don't skip meals and get hungry and then eat too much and eat the wrong things. And salt. We know that salt is a risk factor for MS. Salt seems to promote inflammation, and they've shown this, that people that had higher salt intakes had more MS relapses. And sugar, we all know sugar is a poison in general. And fat. And this is Dr. Swank, going back many years. Dr. Swank, one of the pioneers of MS and eating healthy. Dr. Swank wrote the Swank diet that you've all seen. And he said his initial part of his diet is avoid saturated fats. He believed in that. And Dr. Swank lived till 99 years of age. And I didn't know him. Did you ever meet him, Joe? You did meet him? And I know Bill Sher might have met him. We actually trained with him. And, he lived to 99. I like to think that he ate what he spoke about and ate a healthy diet. So salt and sugar and avoiding saturated fats and eating unsaturated fats. And sugar we know is a toxin. There is work about when you talk about sugar, you could talk about what about artificial sweeteners. And there's talk about that. Do they cause migraines? Do they cause MS? There's no good facts about that. But there recently was a very interesting paper from the Weizmann Institute in Israel in which they said that what the artificial sweeteners actually do is that they're not toxic in themselves, but they are toxic to your gut. They change the bacteria in your gut. And by changing the bacteria in your gut is why they have effects on your immune system. And then eat more fiber, more plants, more fluids, and watch out for alcohol. And the supplements, we talked about D and B12. And here's something about the plants. You may have watched Joel Furman on PBS. Talks about the plants. Colored vegetables, onions, mushrooms, berries and beans and seeds, making these really the foundation or the most important part of your diet. And vitamin D. Now, talk about that. Vitamin D is an immunomodulator. We consider it to have some action on the immune system directly, and there are vitamin D receptors widespread throughout the body in many organs, in the kidneys, the intestines, all over the place. There are vitamin D receptors. And the vitamin D binds to these receptors. They're called vitamin D receptors. VDR stands for vitamin D receptors. And to saturate them, we want a vitamin D level of 75. So when you come to my office, I'm going to say, have you had a vitamin D test? I'm going to test it. And if you have had a test, I want to see the result. Because many times people, the normal range may be in most labs 30 to 100, and you'll go to a primary care doctor and you're 45 and he says, you're good. You're not good enough for MS. We want your vitamin D receptors to be saturated, 75. And there's ongoing multiple studies now using mega doses of vitamin D. And in addition, with vitamin D, what they've shown is that you can look at the vitamin D level, and if it's low, in the study that they looked at, below 25 or above 50, people with lower levels had a higher rate of progression and more active relapses with their MS. And here is salt. I've touched on it briefly, so I won't go into more detail here, other than to say that they looked at people at salt in the diet, and that people that had higher salt intake had more relapses, and they could actually calculate the risk. So salt is another risk factor. Don't cook with salt. Use other seasoning. Don't add salt. Don't put salt on your table. This is some of my references that I put up every time. I think these are excellent books. They're all going to be on the internet. You're going to see them in the YouTube. So these are some very good books that I have found very interesting, and some authors that I think are really, if you follow what they've recommended about diet, I think you can really put together a very healthy diet. And what about this one? High BMI, your metabolic index. If that's high in young adulthood, it's linked to a higher risk for MS. So we must look at a young adult and maybe even teenagers. If you have children, especially this has been shown in, for example, teenage girls and young adults, if they're overweight, if they're obese, if they have a high BMI, they have a higher risk for MS. So we've identified, I've already spoken to you about some risk factors for MS being vitamin D and your diet, especially if you have a high BMI. Those are some risk factors. Going forward, we'd like to be able to talk to you like you do with cardiovascular disease. You see the cardiologist and he says to you, eat healthy, stop smoking, avoid saturated fats, exercise. The cardiologist is teaching you about preventive medicine. We want to do the same with MS. We want to say, how do you prevent this disease? What do you do to prevent the disease progressing? I've spoken to you about taking vitamin D, eating healthy. And in children, if you have children, make sure that they're healthy and exercising and not developing as they become teenagers, that they're not vitamin D deficient as teenagers, that they don't have a high BMI as teenagers. And now what about the gastrointestinal tract? It's becoming more and more important in MS. And so that's why I titled this A Gut Reaction to MS, which comes from the Momentum magazine. What's the relationship of the gut to the immune system to MS? And there are millions or trillions of bacteria that live in your gastrointestinal tract. And they've looked at these actually now, and they've said that if you look at the bacteria in your gastrointestinal tract, they might actually be different in someone who has MS from someone who doesn't have MS. And maybe if you change your diet, you can actually change these bacteria. How do you change them? By what you eat. You might need antibiotics, you might need probiotics. Changing all these things could change the bacteria in your gastrointestinal tract, which could change your immune system, which could maybe have some effect on your MS. This is all under a great deal of study. And with thanks to Dr. Burks, there's an item on parasites. That intestinal parasite infection actually seems to reduce MS symptoms. So what they did is they looked at countries where there are parasites, and they treated the people for the parasites. And when they started treating them for parasites, guess what happened to their MS? It became more. They started seeing more MS. So the parasites were doing something in the gastrointestinal tract. When you killed them, the gastrointestinal tract flora was modified and people got more MS. So there are now actually ongoing studies where they're actually giving people certain types of parasites to see if that can modify your gastrointestinal tract. So what you put in to your body is very important. Smoking and MS. Another risk factor we've identified to add to the list. Smoking increases many aspects. So if you have MS early on and you smoke, you might have a higher risk of converting from your first episode to definite MS. If you have relapsing MS and you smoke, there's a higher risk of becoming progressive. So smoking increases your risk of progression with MS. This slide came in again. And so I'm toward the end now, talking about mental health. So we talked about the invisible symptoms, and I'm talking over here about the invisible self. And that is, when you get MS, do not become another person. Be yourself. If other people see you as another person, then you need to change them. You don't need to change them. And it's not easy. I'm not saying that's easy, but change them. Change the toxic people around you. Find nicer people around you who recognize you for who you are. You may be different. It's a new chapter, but change the people around you. People who get to know you and spend time with you. And I put in over here some of the things that are encompassed by mental health. Look at this, how important this topic is. Couldn't we make a day of this or a morning, how important these things are? Anxiety and depression. How many of us feel anxiety and depression, whatever it may be? Whether it's going to see a doctor with a white coat, or whether it's driving there, or starting a new drug, or meeting someone, whatever it is, anxiety and depression. Memory exercises, cognitive exercises, and clutter management. This is becoming an item that I'm trying to talk to people about. Organization. So you get home and you look at your desk and there's just like mail and there's papers and there's stuff lying all over the place. We need to get rid of this clutter in our lives. Half the stuff we don't need. If you move out, what's the first thing you do? Probably throw out half of your stuff. I just moved from one office to another. Guess how much stuff I threw out? A ton of stuff. I still have too much. I still took things. But you know, you need to be uncluttered. It's very important. Go home and start looking and say, I don't need this anymore. And start fresh from the new stuff that comes in. Work on it right away. Keep it organized. Clutter management will help you deal with this condition much better. You can do things that are more fun instead of worrying about being organized. And then joining support groups of different types. MS Society support groups, this type of support group. You sit at a table, you meet people, you learn new things. And then things that we know about, a bucket list. Everybody talks about a bucket list of what to do. I'm not talking about going to the Antarctic. I'm not talking about going to see the Taj Mahal. I'm talking about things that you do from day to day. And a bucket list of what not to do, because they're very related. For example, forgiveness, patience, generosity, respect, loyalty, gratitude. All from that wonderful book called The Power of Kindness, The Power of Kindness. So if people around you are impatient or not generous, find people who are. And at the same time, become that yourself. So sometimes people say, well, they show no gratitude. Isn't that something in our society? How much gratitude you see out there? You're driving your car, you let someone in, and how often do you see a hand go up? Thanks. Isn't that nice? How about thank you? The little words that are disappearing from our society. Please, thank you, I appreciate it, you're welcome. Aren't those nice words to make the day? And if someone does it for you, say it to them. But at the same time, they should say it to you as well. We should be interacting like this in our society all the time. Be patient. So you're in a line at the supermarket and someone in front of you is a little slow. You know, be patient. So what? So you'll pay 2 minutes later. You know, I mean, we all need to be a little bit patient and understanding. And if every day one of us did, you can see this, where this is all leading to this kindness, these random acts of kindness. If all of us did, each one of us, one random act of kindness a day, think about that. Showed patience in the line at the supermarket, in the traffic. So you're trying to get into the traffic, and what does the person do? Speed up. Now, I'm not letting you in. How dare you come in front of me? Really? Wow. As opposed to just saying, thank you. It's nice. I appreciate it. Thanks. Something like, it's just nice for all of us to have that. Gratitude, patience, loyalty, honesty, compassion. I have to have compassion in my practice, Dr. Burks. We have to have compassion every day. It's not easy sitting day after day and seeing 10, 15 people a day that are hardly ever saying, I feel great, that's why I'm here. It's not usually what they're, sometimes they are, and that's nice. But often they have issues, and our job is to listen and say, this is how we think we can help you. We can't always, we don't have miracles, but this is our job, and each one of us needs to do that. So I spoke about this briefly, and I'm kind of ending off here. The office visit, the importance of it. It's your time when you meet the neurologist, and it's the most important time. It's the time you get, because when you leave the office, it's much more difficult. So how often does someone leave the office and call 10 minutes later and say, I forgot to ask you a question? That's not the time to do it. This is the time. So write down when you come in, make a list of these things. Write down your chief complaint. My chief complaint today is, I'm here for a routine visit and I feel great. I like that one. I don't always get that. My chief complaint today is my bladder's not working, or I have pain, or whatever it might be. I don't think the drug's working, I'm having relapses. Write down your chief complaint. Write down all your medications and supplements, every one of them. Keep the list with you every time. Write down your questions. You hand me this when you come in. You come into the office, you give me a piece of paper with all those things on it. I can look at this in 7 seconds, and I can make this a very meaningful visit. As opposed to, well, I forgot this, and then you're at the door, and now we've sat there for 30 minutes, and there's 3 other people outside, and now you've sat there 35 minutes, and you said, oh, I forgot to ask you about my bladder. Wow. Your bladder? Well, we can deal with that in 1 second, right? That's easy. Not exactly. So it's important to do this and give it to your neurologist and makes the visit meaningful. I can't see, Stuart. 3? Okay. I have 3 more hours. And then finally is the summary. And what I like to do is at the end of the visit is to say, okay, today, this is what, even sometimes I'll ask the person directly, what do you think I'm going to put in my electronic note? And you have a long time to think about it because I type slow. So what do you think I'm going to put in my electronic note today? And they're going to say, okay, you put in the note today, I need to take my vitamin D, I need to get my lab done, and I need to exercise, for example, or whatever it might be. At the end of the visit, we're going to summarize this and go over these important points. And so this is what I finally said over here is the pillars of what we've been talking about, what I want you to do, which is take vitamin D, your diet is important, avoid salt particularly, don't smoke, exercise, your mental health, have a sense of purpose, things to do, the support you get, the support you give. Because, believe it or not, you do important things too. Everybody has something to give. And so that's pretty much the end. I'm not going to do this. We're running out of time. The goals of treatment, and Dr. Burks will go over some of that. What happens if you don't treat MS? That's why you're going to hear from Dr. Burks about treating MS, because what happens if you don't treat MS is that a small number of people, about 10 to 20% of people, have benign MS, which is very mild. You examine them, they have no disability. And 5% of people have very severe, rapidly progressive MS. But the majority of people are in between, and they have relapsing MS, and if we don't treat them, what happens? In 15 years, 50% of them have progressed. And in 25 years, 80% of them have progressed. And so this is highlighting for you the importance of us treating the MS. And so with that, I thank you for your attention, and welcome Dr. Burks.
So our thanks, Dr. Steingo. Dr. Steingo, Dr. Steingo. Dr. Steingo, we have something for you. We have a certificate of appreciation for you. Thank you very much. And again, my name is Stuart Schlossman. I forgot to thank our volunteers, staff, and everybody else that helped us put together this program today. So I want to say thank you to all of them, my family, and whomever. Thank you. And now we have Dr. Jack Burks, and for those that don't know about him, he'll tell you.
Thank you very much. It's a real pleasure to be here. I'm going to start with my thank yous. These are my topics, but I have to say thank you to Stuart. What an amazing man this is to bring this information to... And no wonder his voice is going. He does this so well and so often. And I think we're just very fortunate to have someone of his energy and insights bringing the the information about multiple sclerosis internationally. And so I think it's really great. And I also want to thank him for the opportunity to share the platform with Dr. Brian Steingo. I hope you listen to his talk and watch his talk over again in the YouTube. It's words to live by. I can sit here and talk about science, but you have to go home and live every day. And what he told you is the way to help your MS yourself, not just depend on doctors handing you pills or shots. So thank you, Dr. Steingold, for that. And today I'm going to talk about a number of topics, as you can see on the slide. But I'm not going to give any of these topics their due, and I apologize. I spent my early career in Denver, Colorado at the Rocky Mountain Multiple Sclerosis Center, which I founded in the mid-1970s. Shows you how old I am. So today I'm going to go back to the Mile High and give you a Mile High overview of lots of different topics. And my goal is not for you to memorize everything on these slides, but to take the slides, to look at the different treatments, go home and research them yourselves. Because in that way, you become better consumers of your own health. You become more knowledgeable when you talk to your healthcare professional about this option, this option, this option. I can't cover the 35 treatments I'm going to talk about today, but I can tell you what they are, stimulate your curiosity and interest, and hopefully you'll be able to spend time after this presentation becoming better consumers of your own health. I'm going to plug this. This is from the Multiple Sclerosis Association of America. It's called the MS Research Update. Much of what I'm going to talk about is from this monograph. And you can go on the website. It's absolutely free. And I'll have a copy up here as well if you'd like to take a look at it briefly. But it's a chance written for the lay population of taking everything that's happened in 2014 and say, this is where things are going. Now, we wrote that maybe, I don't know, several months ago. And in those several months, I'm now going to add another 15 new emerging therapies. That's how fast the research is going. It is absolutely amazing. And so with that, I'm going to start. Let me just go back. I'm going to talk about a number of topics. I'm going to talk about MS relapses. None of these topics get their due. Each of these is a half an hour, 45-minute talk, but I want to give you an update on what's going on. Myelin. Everybody talks about myelin and myelin repair, and then we talk about stem cells, what's going on with stem cells, and then I'm going to talk about 35 other emerging therapies, just briefly, to give you this overview. So let's start. Well, first of all, I'm the Chief Medical Officer of the MSAA, so this is from this publication. And I have a consulting educational business, and I'm also a clinical professor of neurology at Florida International University. I want to start by thanking Dr. Steingo, who you just heard a wonderful talk, and Dr. Stephen Krieger from Mount Sinai Comprehensive MS Center, who have loaned me some of their slides to share with you today. Thank you very much. And I can tell you the next time you hear me talk, I'm going to borrow more of Dr. Steingo's slides because he gave such great slides. So thank you in advance. Let's talk about MS relapses. About 85% of people with MS begin with an MS relapse. This is due to acute inflammation in the brain. The lymphocytes get activated, they get into the brain, and they cause damage in different parts of the brain, and they do it acutely. So we see things like vision problems, balance problem, weakness, numbness, fatigue, and many others. The key between this and a good day or a bad day, a real relapse lasts for 24 to 48 hours at least. So this is not something that when your kids come home from school and they ask you, why isn't dinner ready? And all of a sudden you don't feel very good, but you're okay later. That's not a relapse. It has to last for at least 24 hours, having objective symptoms. And there's usually improvement over from a few weeks to months, even without treatment, although the treatments for relapses can shorten that attack dramatically. And so the treatments are high-dose steroids. You can give it intravenously, or you can give it orally. Most of us give it intravenously because we think that may work faster. And then the next therapy that's making a comeback is ACTH. It's an injection. It has two types of effects. It has a steroid type of effect, which the steroids do, and which is great. But there's now scientific evidence that it may have another type of effect as well. And it's called melanocortin stimulation, or it's looking at the melanocortin pathways for reducing inflammation, which may be different than the steroid pathway. So may have two pathways working. So that's exciting to think about another way to possibly look at reducing this inflammation in the brain. And for people who fail those, we sometimes have to use plasmapheresis. It's an intravenous removal of the antibodies in the bloodstream. Doesn't happen very often. And it's for people who really fail the other therapies. It's not a first-line therapy. Well, I usually stop there. Okay, that's the treatment. But the fact is there's a lot more treatments. And some of this is incorporated into Dr. Steingo's talk. The treatments of the symptoms, which you heard from Dr. Steingo. Rehabilitation. You may need help with your walking, your balance, your thinking, your speech during an attack. Well, you can get help for that. And then there's this other thing that we do when a patient has a relapse. We talk about how to prevent relapses. And again, Dr. Steingo mentioned stop smoking, low-salt diet, making sure you take your medications. There's this saying, if you don't take your medications, they don't work. And the medications are one of their primary design is to stop you from having relapses or reduce that number dramatically. So it's really a time to stop and think, do I really need to start taking my medicines more regularly? Another thing that happens during a relapse is that it's the opportunity to provide psychological support. And last but clearly not least, it's a time to really stop and think about the importance of caregiver in your lives and those important people and provide support for them as well. So I was talking about relapses must last 24 hours. What if they don't? What if there are other situations? Not everything that causes new symptoms is a relapse. You can get temporary increase in your symptoms not related to this inflammation or myelin damage, like with a urinary tract infection or really a fever of any kind. When you get overheated, when you overexert yourself, you can feel some of your symptoms, especially coming back that you've had before. That's not necessarily a relapse. Psychological stress can do it as well. And the treatments for pseudo-exacerbations or pseudo-relapses is actually treating the underlying cause. If you have a bladder infection, treat the bladder infection. You don't give those people steroids. It's not appropriate. You treat their bladder infections. So therefore, just because you have new symptoms doesn't mean you're having a relapse. Let's move on to myelin. I want to talk about what myelin looks like, because I'm not sure you've seen this pictures. I thought these are great pictures. And again, these are Dr. Krieger brought these to my attention. Here is the neuron, the thinking cell in the brain. And outside the neuron is a wire that connects to the body. And there are these patches of myelin, this insulation, this covering. And that's what it looks like schematically. The neuron sends the message down to the body, and that wire has to be protected, has to be insulated. And the myelin is the insulating material. And in MS, what you see is actually, this is what it should normally look like here. But here there's a thinning of the myelin. Right here, you can see this myelin up here looks good. Myelin down here does not look good. And when that happens, the insulation goes away. And when the insulation goes away, the message gets short-circuited. This is an electrical connection. So you need the insulation to conduct impulses and messages in the brain to the body. This is what a picture of a brain looks like from a patient who had MS. You're not going to see this very often, but I thought it was important to try to talk to you about what it actually looks like. This patch, there's a patch here, there's a patch here. These are the ventricles. This is the thinking part of the brain out here, the gray matter. This is the white matter. This is where the myelin resides for the most part. These are lakes called ventricles of spinal fluid. And around these ventricles, you'll see areas that should be white, and they're not. They're damaged. They're damaged. They're damaged here. That's what myelin damage looks like in an autopsy. That shows you some of the areas where the myelin is damaged. What about how does myelin damage look like on an MRI? Well, again, I'm going to bring your attention to, this is the skull, this is the nose and the mouth. These are those lakes in the middle of the brain that I showed you about. Here's the top part of the brain, the gray matter where the neurons are. This is the middle part. This is where the myelin is. And you can see this should be homogeneous. There's a spot, there's a spot, there's a spot. And you can see spots over here. That's what myelin looks like in the brain. And again, this just points out some of those spots. Okay. So myelin, it's the insulating coating of the wires. You need a fast connection, and you don't get a fast connection if you don't have the insulation. And the cells that make myelin are called oligodendroglial cells, or oligos, and they're damaged. And when they're damaged, then the wire gets damaged. And when the wire gets damaged, also the neurons get damaged. So it's not just a myelin problem, it's a myelin problem that causes also problems with the wires and the thinking cells, the neurons themselves. So what's new? Well, it turns out there's a lot of work being done at the University of California, San Francisco, that actually have a screening mechanism that can test potential treatments to repair myelin. So now we have all sorts of opportunities to look at literally thousands of potential treatments for myelin in a model, so we can pick out the 2 or 3 that might work and then try those in humans. It's an incredible breakthrough in trying to develop ways to increase the myelin. In addition, we talk about MRIs, and I showed you the MRIs, but the sophistication of other imaging is incredible. So that's really new. We can actually look and see what's happening to the water content in the myelin areas and things like that. It's very exciting. These are the sort of things that are going to bring new treatments to stop the damage from myelin and repair the damage. There are some treatments actively being evaluated right now. So it isn't like we haven't done anything yet. There's a drug called anti-LINGO antibody. And so what is that? Okay, LINGO is a molecule that blocks myelin repair. That's not good for MS patients. So therefore, they've made an antibody against the LINGO that stops the LINGO from stopping the damage and stopping the ability to repair the myelin. And they tried it in an animal model. It worked. Now they've got it in human trials right now. So we're very excited about the possibility of having something that really focuses on myelin repair and regeneration. It's very exciting news. Another one is NDC 1308. These are just names. But mainly it's a hormone that restores myelin by stimulating these myelin-making cells, these oligodendroglial cells. They actually can be stimulated to make myelin. And also, just recently, there's been a new molecule called contactin-1. You probably haven't heard about this one yet. But it also promotes myelin growth and function, not only on the oligos, but also on the myelin itself and the axons that it coats. So therefore, if we can figure out a way to stimulate this molecule to make more myelin, we've hit a home run. That's the sort of research that's going on. And there's also an antibody that's been reported that promotes myelin repair. So it's coming. It's coming. Stem cells. I wish I could tell you about stem cells. We've got the stem cells, and tomorrow you can get them. And there are some recent pilot data that look encouraging for stem cells. But it's just not ready for prime time yet. We need much more scientific data. It's not ready for commercial use, and I really don't recommend you going to Mexico or wherever else you want to go to get stem cells. We don't know enough, and I'll show that on the next slide. We don't have enough efficacy data. Are they effective? And we don't have enough safety data. Here's the things we don't know. We don't know what cells should be used, how to prepare them. Should you get them from embryos, from the fetus, from the umbilical cord? And if we don't get it from the same patient, well, then we may take stem cells from me and give it to you. Well, then that may go through, that's like a transplant. It may go through rejection. So then you have to immunosuppress the patients for that. That's not a great idea. We really need it from the patients themselves. So we can get precursor stem cells from bone marrow, from fat cells, and even skin cells. Can you imagine the work that's going on that's promoting this? It's just terrific. And then once you get the cells you think that might be helpful, you've got to figure out how to give them. And depending on how you give them, will they get into the brain to do their work? Well, this is some of the encouraging work that's going on, but not ready. So I'm not recommending that you go to stem cell clinics for multiple sclerosis right now. But just know that the research is really looking very encouraging. We're just not there. So I'm going to end by talking about emerging therapies. I'm going to start by all the people in this room who have progressive disease. We don't have a treatment for progressive disease. There's no FDA-approved treatment. But I can tell you, of the 35 treatments I'm going to talk to you about, many of them are aimed at progressive disease. We're learning about remyelination. We're learning about preventing degeneration in the brain, which is mainly in the progressive form of the disease that we see. We are really making progress. And my goal is to stimulate you, especially people with progressive disease, to look up some of these things I'm talking about when I talk about progressive disease, and you'll see how exciting it can be. Every meeting I go to has a handful of more treatments that are being used, and many of them for progressive disease. This book that was written, this monograph written a few months ago, we've had much more to add to it just in the last few months. It's very exciting. And that we're also going to see more and more pipeline drugs. And I will go into that. But I'm going to start with the drug that is in front of the FDA right now. They'll make a decision, I think, within the next month or two about whether it's going to be on the market. So I want to tell you more about that than some of the others, because I'm going to give the others short shrift, frankly, because I'd love to talk this much about all the treatments. But I'm going to talk about Lemtrada, alemtuzumab. It's a monoclonal antibody, and that hopefully we'll hear in the next month or two whether it's approved. But it knocks out both B cells and T cells. Many of the treatments are now aimed at T cells, but not B cells. And now we've got some that I'm going to talk about that are aimed at B cells. This actually does both. It is a very powerful drug. You only have to take it 5 days the first year intravenously, no more. That doesn't mean you quit, because you have to be studied because of some of the issues. You need to have testing done on a regular basis, but it's a 5-day treatment. After that, maybe it's 3 days. So you're really talking about very little time getting these intravenous infusions. Now we give them with intravenous steroids, because when you knock out all those white blood cells all at the same time, and they break up, it floods the body with all these things, these potentially toxic things, and the steroids can reduce some of that. And the results that the FDA is looking at is a comparison of Lemtrada versus a very good high-dose interferon, and it compared very favorably to that. There was a very low relapse rate, maybe one attack every 8-9 years. Very impressive. The disability scores, many of these people improved. Now, we don't talk about that in clinical trials. People improving? I mean, it's exciting. And the MRI data was spectacular. It was really very good MRI data. Now, there's always the other side. We talk about efficacy and strength, but what about adverse events? What about side effects? That sort of stuff. Well, we have to be careful. Thyroid problems can occur in 25 to 30% of the people. That's the bad news. The good news is they're treatable if they're picked up. The bad news is that 1 to 3% of the people may have their platelet counts go down, which is the blood clotting cells. The good news, it's treatable, but you have to get your blood test done to make sure that you have it, and then you get treated. Kidney toxicity less than 1%, but you have to watch for it. And then these infusion reactions, because you're knocking out all these cells so quickly with the infusion, and that's why we give the steroids. Those are the things to keep in mind. One of my biggest concerns about Lemtrada is that if you only have to take a drug for 5 days, and then you don't have to take anything else for another year or more maybe, you forget about it. I'm feeling great, doing great. I don't need to get checked. I'm happy. You know, if I were sick, I'd know it. That's my big fear. There's going to be mandatory safety concerns. You're going to have blood tests done on a regular basis to check to make sure that your body is doing okay. So if you have a problem, you get it treated before it becomes a serious problem. And so keep that in mind when you think about Lemtrada. It's not a 5-day treatment. It's a 5-day treatment with regular monitoring. Laquinimod is another drug that I think has great potential. It's a drug that appears to have possible neuroprotection. It helps disability. The disability data is even more powerful than the inflammation data. And that's really different because these other drugs have all been, we knock out inflammation. If we knock out inflammation, good things happen. But now we're talking about a drug that may actually have direct action on disability. And there's a trial going on right now. Now I've got 28 other things to talk about very quickly. And I apologize. These are important drugs that we really need to give at least 5 or 10 minutes to, and we don't have the time. Rituximab. Again, it's a B-cell treatment, not a T-cell treatment. It's a B-cell treatment. And they're using it in a secondary progressive disease, and the results should be known in 2016. They did a preliminary trial a few years ago, and there was some encouraging data. If you get secondary progressive disease early in the disease, it might be helpful. So we're hoping that we see more results like that. And then there are 4 drugs that I've listed here that are similar to Gilenya. They basically keep activated lymphocytes in the lymph nodes. They don't kill anything. You know, these lymphocytes circulate before they go into the brain, so they put them into the lymphocytes and they sequester them in the lymph nodes. So these activated cells are sequestered, can't escape the lymph nodes, so they can't get into the brain to cause the damage. Well, it's such a promising area that there are now 4 other treatments that are being tested with that same mechanism. There's a T-cell vaccine where you take activated lymphocytes, you remove them, you inactivate them, and then you put them back into the patient. And there's encouraging pilot results. The statins, the anti-cholesterol drugs, well, there is some data that says the statins may be helpful. It's not ready for prime time yet, so don't go out and start taking Crestor or whatever. But the data looks encouraging. We're going to hear more about that. I consider it an emerging therapy. Tisabri, you know about Tisabri? It's a major treatment for relapsing remitting disease. It can be very helpful. Well, now they're testing it in secondary progressive disease as well. So if it's helpful in relapsing remitting, maybe it'll be helpful in secondary progressive. Diclizumab, again, I'm not giving it its fair shake. We should have more information to give you this, but it's another monoclonal antibody. And the key is it treats patients, you only have to treat patients once a month with this. And again, the early data is very encouraging. Gilenya, you know about Gilenya. It's an oral treatment for relapsing remitting MS. They have a trial on primary progressive disease that we should know the answers in the next few months. It's almost over. So we might have a treatment for primary progressive disease that's proven in the next few months. And we might not. You know, we don't know. Nobody knows the answers yet. But at least they're trying. They're saying it's important to try to find treatments for primary progressive. And they're going at it now with Gilenya. Ocrelizumab, it's another B-cell treatment. Again, very encouraging preliminary results. Amilordide is available. It's a blood pressure medicine. It's a heart medicine. You know, if you have heart disease or blood pressure problems, you can get it. Well, it turns out the way it works is there's too much salt that gets into the cells. And by reducing this buildup, we may be able to prevent the degeneration. Dr. Steingo talked about salt. I'm going to talk about it again. Salt is bad news for people with MS. It's probably bad news for all of us. And Dr. Steingo mentioned about really not adding salt. Well, I've been surprised, since this has come up in the last year, I've been looking at the processed foods I buy, all those frozen foods. It's disgusting how much salt is in those foods. Think about that. Okay. Riluzole is a treatment for amyotrophic lateral sclerosis. Lou Gehrig's disease is a degenerative disease. They're going to try it in MS, to maybe it can protect the brain from MS. Butylast is an asthma drug. It's a very good asthma drug. It may also have neuroprotective properties that's being looked at. These are drugs that are being studied right now. Idabinone, it's like coenzyme Q. Now, I'm not telling you to go out and buy coenzyme Q right now, but it works the same way, and it's an antioxidant. It may be neuroprotective. We don't know. We don't have the data, but it's a treatment that's being looked at. Okay, so there are other cells in the inflammation sides that we talked about, these lymphocytes, but there's also something called mast cells. It turns out mast cells may be contributing to the damage in MS. And so therefore, there is a drug out being tested right now called Mastanib, and it knocks out mast cells. And there's some preliminary data that look good. What about estrogen? Can estrogen be the treatment for MS? We know that when women get pregnant, they're much less likely to have an attack. Maybe it's estrogen. So we're looking at the estrogen compound called estriol to may decrease the damage because of the known fact that women who are pregnant have less MS attacks. There's something called MIS 416. I know these mean nothing to you, but you're going to hear about them, so I'm going to tell you about them. It's something that helps fight infections, but it also may help MS, and there's some data on that. Transderm peptides. That means you put an injection into the skin, and these myelin products into the skin. And when you put them into the skin, something happens in the skin because the immune system is in the skin. It's in the gut. It's in different places. But if you put it in the skin, it reacts in such a way is that it may tolerize the lymphocytes from destroying myelin. Wow, that's really far out. Well, I just heard a talk about that recently. It's not far out. You know, it's something we really need to keep an eye out on. The relapse rate was decreased by 65%. That compares very favorably to current medications. There's a drug for seizures called Dilantin or phenytoin. It blocks sodium in the cells that Dr. Steingo was talking about. It may be helpful in preventing damage in MS. Axona, Dr. Steingo just mentioned. I thought it was cool because it's a medical food. It's basically coconut oil. Coconut oil produces good fatty acids. The good fatty acids produces ketones. The ketones are used by the brain for energy. It's being used in Alzheimer's. Again, I'm not recommending if you have a friend with Alzheimer's, they go on this. But it may create more energy in the brain. Anyway, a medical food. And I appreciate Dr. Steingold mentioning it. Ofatumumab. It's another B-cell treatment. So that's the third B-cell treatment I've talked about, because before we only talked about T-cell treatments. Now I've talked about 3 B-cell treatments. Erythropoietin is a kidney hormone that increases red blood cells, but also may have protective effect in the brain. There's a drug, next one I won't even talk about pronouncing it, but it's a monoclonal antibody that knocks out one of the most toxic lymphocytes, the most activated lymphocytes, called the Th17 cells. I'm really looking forward to getting the final results of this. And then there are others. RTL1000, it decreases inflammation. SB 683699, I'm glad I got that out. Again, it blocks these activated lymphocytes from getting into the brain, very much like Tisabri. Then there's one called XP 23829, which is like Tecfidera. It's not Tecfidera, but it's in that same mechanism. That may be very helpful. Lipoic acid is an antioxidant, possibly neuroprotective. Minocycline, a tetracycline, is an antibiotic, but it also has anti-inflammatory effects. That there's some preliminary data from Canada that looks very interesting. I'm going to end this by talking about biosimilars and biogenerics, because you're going to hear about them. These are drugs that are synthetically made or made by other companies that are sort of copycats, and that there are currently trials being done with copycats or biogenerics to Copaxone and also biosimilars to interferons. So we're going to see this. I mean, it's in front of the FDA right now, this issue. And the question that I have is that there are rules that you know, if you make a biogeneric for aspirin, you don't have to treat patients. It's a chemical. Who cares? You know, all the chemicals are the same if you make the chemical formulation right, but MS is much more complex. And so the question comes up, is our clinical trials going to be mandatory? Or can you really make a copycat biogeneric drug without any risk? It'll be exactly the same efficacy and exactly the same toxicity. Well, that's still being debated. And so that's something in front of the FDA right now. So in summary, MS research is producing many new therapies to reduce the damage and also to stimulate repair. I predict 3 to 5 will be ready for FDA review in the next couple of years. And so the take-home message for you is be encouraged. And be encouraged especially if you have progressive disease. How many years have I been giving talks and saying, oh, progressive disease, tough luck, sorry. Well, I'm not saying that now. I'm saying we've got things that are being tested now that look very promising. And also, the reason for going through this and for you to go home and do your homework is to be more knowledgeable about these therapies. Because as they become available, you can ask your doctor about them. You can find out information from the internet. And I'll leave you with the statement that therapies do not work if you don't take them. I did a recent study looking at people who were on medications that clearly can help people with MS. And we looked at the number of attacks they had, which was the number of people who got steroids. And did they get their prescriptions refilled? Guess what? People who didn't get their prescriptions refilled had attacks. People who did get their prescriptions refilled didn't have attacks. It didn't matter what drug they were on at that particular time. There was a difference for people who took their medicines versus not. So the key is, you may be feeling great. You may not have attacked in a year. That's not a reason to stop taking your medicine. That's a reason to continue to take your medicine. So please keep that in mind. Stay adherent to your medications. If you're having trouble with your medications, talk to your doctor. And I wish you all the very best. Thank you for listening.
None of these speakers are allowed to run away until we give them their certificate of appreciation. So thank you. Thank you. Thank you. So now we're going to open the floor to Q&A, okay? And so we're going to ask both doctors to come on up, and you're going to take turns at the podium here because you'll figure out who's going to answer which question.
Good morning, everyone. This is for Dr. Burks. Dr. Burks, a question that you were saying about stem cell, that it's not here, but why has it been such a positive feedback in Europe? Why isn't it being done here?
You sure you don't want to take this one? No. I think that it's not approved in Europe, just so you know. So there's not been enough data in Europe that has convinced the European regulators to release this or to approve this drug. And I think there's been some really good work being done in the United States as well. Cleveland Clinic just presented some preliminary data on stem cells that it looked like they could give it safely. They're still working out the dose and the way to give it. So I think that we don't know the answers. And when you do small studies without controls, we don't know about the placebo effect. We know that if people go into clinical trials and they get a placebo and they take good care of themselves and they get a lot of psychological help, et cetera, guess what? They do well too. So we have to have rigorous trials. And the rigor of the trials and the numbers of the patients being treated are not enough yet to make any conclusions right now. And so I don't recommend you going anywhere until we get better data. Do you want to?
My turn? Yeah. Okay. Probiotics. We're talking about having bacteria or lack of bacteria in the gut that is not always good. There's a number of probiotic supplements, whatever you want to call them, on the market, and they go by how many billion of active cultures are in them. My question is, how do you choose a probiotic? How many billions of active cultures do you need?
So there's no studies that have been, there's no studies. So I would call probiotics, so we use the words alternative or complementary. And so taking probiotics would be complementary. I don't think there's alternative treatments to what we've spoken about to MS. Everything we've spoken about is all the mainline treatment, and then there's complementary treatment. And taking probiotics, of which there's different types, would be something that I would consider. And there's no studies that have been done as to the number. We know that there are trillions of bacteria in the gastrointestinal tract. So all I say to someone right now is that as the evidence we have suggests that probiotics could be beneficial, but you should go to a well-known, get them, don't get them from some shady place. Get a well-known brand, get something from a reliable source, and that's what I would recommend, something like that. We can't tell you the exact dose. It hasn't been studied. There's no trial. Sure.
Just comment. I'm really glad you brought that up. I was watching Dr. Oz yesterday, which I don't admit to doing. And they had this discussion. And there's not a lot of data, but there's a lot of concepts that are really good and that we don't really understand. We have paid no attention to the gut, as far as I'm concerned, to the last few years. But the gut is a very active immunologic system in our body. And you can change that gut in a number of ways. And it's coming. It's coming. I was at a meeting, an international meeting a few weeks ago in Boston, and there were only about 3 papers on it, but I listened to all 3 of them, and it was very interesting that we may be able to change our immune system by changing our gut, the microbes or the bacteria in our gut. I take probiotics. I take the standard brand. I have no idea which one's the best. But I think that probiotics is a way to try to stimulate the gut to be less toxic in a way.
I have a question from this side of the
before
room.
Before your question, just to add to that point, is taking probiotics is part of the whole program to modify your. It's not the only thing. You shouldn't just say, well, I can eat whatever I want because I'm taking probiotics. You have to do everything else for your gastrointestinal tract. For example, just as Dr. Burks mentioned, there's studies now on the gut. We call that the microbiome. If anybody wants to look that up, it's the microbiome, B-I-O-M-E. And that's the little area inside your gastrointestinal tract with all these bacteria. So, for example, there are studies on the effect of meat, red meat, on the microbiome. So look at other things as well that affect the microbiome as in addition to that. Should be part of a whole good plan.
And don't forget what he said about artificial sweeteners. That's very scary.
I have a question from this side of the room. The lady wants to know the relationship between MS and celiac disease, if there is a relationship.
Yes, there's lots of gut questions. So, yes, well, firstly, if someone has MS, let's talk about gastrointestinal disease in general. In people that have MS, there's a higher risk of other autoimmune diseases, especially Crohn's disease and ulcerative colitis. There's an increased risk of Crohn's disease and ulcerative colitis in people with MS or in their families. You often find someone with MS has somebody in the family with colitis or Crohn's disease. Those two particularly. Celiac disease is a disease that is specifically associated with gluten sensitivity. People that have celiac disease should remain free of gluten. And that's a small percentage of people. There's probably another 5% of people in the population who actually don't have true celiac disease, but they're gluten sensitive. So this is where that comes in. So it's very important if someone feels that they are gluten sensitive or has gastrointestinal problems to check and see if they're gluten sensitive and to stay on a gluten-free diet. I think that's the most important thing. I don't think everybody needs to be on a gluten-free diet. I think, as many of you may know, there was a book written recently by a neurologist, I call him a commercial neurologist in Naples, on gluten-free. He attributed every ailment in the world to gluten and said that whatever you have, you should be off gluten. So he gives examples of people in his clinic that he took them off gluten and they recovered. And some had Parkinson's and some had Alzheimer's and some had autism, all kinds of diseases that he says you should stay off gluten. So I think that's exaggerated. So I think if we have any gastrointestinal symptoms, we should be evaluated for celiac disease. And if we have celiac, we should be gluten-free. Other than that, everything in moderation.
I have a question on this side of the room.
Okay, you had mentioned about vitamin D. I've heard different theories on what amount you should take every day. I've heard some say as much as 10,000, but I've heard if you take over 5,000 a day, then your body doesn't absorb it. What do you recommend?
You the next one. Yes, so here's the answer. You need to measure your vitamin D level. You just go and get a blood test, and we find what your level is, then I tell you how much to take. You might need 5,000, you might need 10,000. So the dose that I'm going to tell you to take depends on your level. It's not just that it's 5,000. Some people need 10,000 a day. I have people that take 12,000 a day, and there's currently studies underway where they're using mega doses, even bigger doses of vitamin D to see what the benefit is. So the dose I'm going to tell you to take depends on your level.
Well, now I have regular blood tests when I have my regular checkups, but I've never heard them mention the vitamin D test that you were talking about. I've never heard them mention those levels.
It's a routine blood test, just like you do all your other blood tests. A routine blood test is a level. Most laboratories have a range of 30 to 100. For MS, we're aiming for about that 75 kind of range, 75, 80, 70 to 80, somewhere in that range. And whatever that is, that's how much we're going to tell you to take. Vitamin D3.
I have a question here.
All right. You mentioned about the salt intake. Now, is it better sea salt than using table salt?
Does it make a difference?
Is there a difference?
I think salt is salt, to be perfectly honest. And I'm not an expert in salt, but from what I've seen, is salt. Is sodium, and sodium chloride gets into your cells. It's not such a good deal, and it stimulates the body's immune system, well, no matter how you get it.
I have a question over here, please.
So a person with MS, what questions should they be concerned about when having surgery?
Just alternate. You just want to alternate? No, so there's this thing that over the years where they've said if you have MS and you have surgery, the MS is going to do, you're going to have a relapse and it's going to affect your MS, and this is generally not true. Most people with MS can undergo surgery and they usually do fine. If the surgery was very complicated and they had major infections, hemorrhage, complications of surgery that stress their immune system, potentially their MS could be activated. But for the most part, people with MS can undergo surgery. We would watch them carefully, but they can undergo surgery. I constantly get this people go and see the dentist and they need a wisdom tooth extracted, and the dentist wants me to clear them to have their wisdom tooth extracted. But we've all had patients that have had bypass surgery, hip replacements, major surgeries, and in general, it's fine to have the surgery. For most people, there's no problem in having surgery.
Well, let me give you my take on that as well, and I certainly agree with what Dr. Steingo said. If you need surgery, get your surgery. If you don't need surgery, why bother? Because surgery does create stress on the body, and it's not been proven, but I don't want any more stress on my body than I need to be, so therefore if you're talking about a facelift or a breast augmentation or a lipo, whatever they do, think about that. It just adds the stress to your body. And so I'd be reluctant to say, oh yeah, just go ahead and have all that sort of stuff. But if you've got a heart bypass problem, you need an operation. If you have really bad back problems, you need an operation. So it shouldn't stop you from doing it. But I don't think we should add stress to the body unnecessarily. And I think the elective surgery is probably unnecessary stress on the body, even though I have no proof that there's no data that says if you get breast augmentation, you're going to have multiple sclerosis more. That does not exist. Just in general, if you need it, take it.
I have a question here. We have shy people on this side that prefer for me to ask the question. This one here says, if I had parasites in the past, should I get tested to see if I still have them? And what kind of test should be done?
This is a lady who's had parasites before. Is that correct?
Whoever gave me this question?
Yes? Okay.
Whoever gave me this question?
That's all right. We'll just assume that. Well, don't worry about it. We don't want people to have to admit that they have parasites.
Yes.
But I'll bet their MS is doing well if they do. Anyway, I think there's a test for parasites. You take a stool sample and you look for parasites. As simple as that. If you want to know if you have parasites, go to your doctor and they can make the arrangements to have the test done. And that have you had lunch? You haven't had lunch, I can tell you this. There's a study at the University of Wisconsin, another study in England, where they're actually giving MS patients ovum parasites. And then they're doing an MRI in 6 months, a year from that to see if their MRI changed. So we're actually looking at what can happen. There was a study done in Argentina that also looked at treatment related to ovum parasites, and there seems to be a relationship there. So therefore, I'm not recommending you go out and start eating dirt, but it's going to help us understand the mechanisms of the disease a lot more. And it would be, as Dr. Steingo said, it might be very interesting if that's connected to the worldwide distribution of MS, because used to be MS was only seen in countries that had good hygiene. Now it's seen everywhere. It's a fascinating study that he talked about.
We have another question over here.
All right. So my question was that I saw in your presentation where you made reference to T cells, and I recall that they're referred to as helper cells with regards to our immune system. The medication would interact with the T cells, and the side effect with that was that we would have thyroid defects. So I was wondering why that was, if the T cells, were kind of linked to the thyroid, as well as how effective is Rituxan.
Okay, I think I got that. Is the T cells' relationship to the thyroid? Was that the that was? Okay. I missed that. Again, let's use the microphone.
If your T cells are question is, if the T cells are low, why do you get thyroid disease? What's the effect of T cells on the thyroid?
Oh, all right. If the T cells are low, why do you get thyroid problems?
What she's saying that when you talked about the T cells, that medication one of the side effects is the thyroid problem.
Yes.
She wants to know why is that connected, the medication, why would that create that thyroid problem?
T cells and B cells.
Right, and
Yes.
I'm saying that the thyroid is related to T cells, right? So if a side effect was thyroid defect, when the T cells are involved, I'm wondering why is that?
Okay. There's an autoimmune process sometimes, and it can affect one of the side effects of this medication is it can stimulate autoimmunity. We think we treat it to stop autoimmunity for MS, but it can also, as a side effect, can cause autoimmunity, can cause it like in the kidney, for example, on rare occasions, can also cause it in the thyroid. And so the specific mechanisms, I don't know. I don't think they've been elucidated, but we know that whenever you give drugs that change the immune system, you can change the immune system two ways, down or up, depending on what cells are affected. You want to comment?
We got a question over here, and then I'm going to just move it towards the back. 1 minute, please.
Yes, my question is regarding the myelin repair. It seems like, from what you're saying, you're more hopeful for the myelin repair. You're waiting on the FDA for approval. You're more hopeful about the myelin repair versus the stem cell. It sounds like the stem cell is so far out there. How hopeful are you about this treatment for myelin repair, and in what time frame you think that would come about?
That's a great question, because I think that stem cell, we're still trying to figure out what cells to use, how to use them, what dose to give, how to measure their effectiveness, et cetera. We know the stem cells, we know that fat cells can turn into stem cells. And we know they can get into the brain, and that's some of the work that was being done in Europe that was so encouraging. But we're still a long ways away from clinical trials. The clinical trial done at the Cleveland Clinic recently really was just looking at dose, and they gave a low dose and it was safe. That's the first thing you do. You give a low dose and see if it's safe. Then you give a higher dose, and you may get it a little bit different ways. So I think that's where stem cells are. They're in the early stages, where that's called a phase 1 study. There's phase 1, phase 2, and phase 3 studies to get to the FDA approval. And the stem cells are in phase 1. The cell that I mentioned, the anti-LINGO antibody, is in phase 2. So that's really a huge step. So now we're looking again at at the dose and toxicity, but also going to look at efficacy. Does it really help people? So the phase 2 study will give us some indication. Is it going to be helpful? And if that's helpful, then we go to the stage 3. The stage 3 trial would probably be another 2 or 3 years. So we're really talking about 4 or 5 years, I think, before we get the anti-myelin, the myelin treatment, the myelin repair strategy out to the patients. Would you agree? Is that, okay?
We got to keep the answers a little bit shorter, more succinct, and big, so we can get more into this room.
I have another question from someone that prefers that I ask it. The relationship between caffeine, alcohol, nicotine, and MS.
I mean, so alcohol in moderation for everybody. If you have a glass of wine, we all know that a glass of wine is evidence that it's beneficial in many ways. I spoke about that too much alcohol. If you have a six-pack, that's a bunch of calories that you don't need. If you have too much alcohol, it's got bad effects on the brain. Brain cells actually die when you have too much alcohol. So alcohol in moderation is fine. So that's not a problem. We spoke about the nicotine already and smoking. That's not good. That's definitely one of the factors that increases the risk for MS. And caffeine in moderation. Caffeine is a stimulant. So if you have some caffeine and you have a cup of coffee, that's a stimulant, that's not a problem. Everything in moderation. But in excess dose, nicotine always a poison. In excess dose, the others also poisonous. So everything in moderation.
I have a question over here, please.
Hi, I'm actually interested in that anti-lingo drug too, and I was just wondering how is it administered, and do we know anything yet, like as far as in the trials, if it's helping people's symptoms by coating the myelin or anything like that, basically?
Well, it's administered by an injection. So it's a monoclonal antibody. And the results in the animal models were very encouraging. We don't have results of the phase 2 human model yet, but we have every reason to think that this may be very helpful. I tried to make that short, Stuart.
I have someone here.
Dr. Steingo, I've been taking 5,000 international units of vitamin D supplement for over 2 years now, and my count has gone from 45 to 36 to 32, and I was wondering if you recommend me upping the dose or getting out into the sun, getting more natural vitamin D3 from the sun. I'm sorry?
Speak louder. Speak louder.
I've been taking 5,000 international units of vitamin D supplement, and my vitamin D count has gone from 45 down to 33 over the last year. And I'm wondering if you recommend increasing the dosage or getting out into the sun, getting more natural vitamin D3.
No, I would increase the dose. So our goal is to get to about 75. If you're taking 5,000 and you're at 43, I'd tell you to take 10,000 and check it again in 3 to 4 months. So we use doses 10,000 regularly. You can actually get a prescription strength of 50,000, a 50,000 unit capsule. And if you took 50,000 once a week, that's equivalent to 7,000 a day, approximately. Or you could take, I have a good number of patients who take 10,000 units daily. So you definitely could increase it. And you might change the brand sometimes, could be the fact. But I would double the dose.
I have a question over here, please.
You've been talking a lot about vitamin D, and I understand its importance. Just a question is...
Please talk louder. There's a lot of noise.
Sure.
With the servers.
The follow-up on a question on the vitamin D was regarding, isn't there 2 tests to test for vitamin D? One is the one you're talking about, and there's another one I just read about to test its efficacy or the other parts of the body. There's one, again, it came from a Dr. Oz thing in the newspaper. And, you take it with a grain of salt, but he did mention there's a second test that is rarely recommended, but also tests how your body's reacting to the vitamin D. Are you aware of that?
I mean, for clinical purposes, all we have is to measure the vitamin D levels. We measure the vitamin D total, the 25-hydroxy vitamin D, and so it's a... Yeah. Right. There's different types of vitamin D. There's D2, there's D3, there's 25-hydroxy. So when we measure it in the lab, we get a total. And it's a routine kind of test that's done. Yeah,
we have to keep the questions to the microphones, please.
25, we recommend vitamin D3 is the one we're going to recommend.
Got a question over here.
Good morning, and thank you for the program. My question regards the gut and possible connections between mononucleosis, diverticulitis I'm sorry?
Please talk in the microphone.
Oh, I'm sorry. I thought you could hear me.
No.
My question is about the gut and possible relationships between mononucleosis, diverticulosis, possibly arthritis, and diabetes. You can check all those on my list. So.
Yeah, all those are important, and the gut may have something to do with all those. Certainly in MS, there's strong evidence that mononucleosis is one of the factors that may play a role in multiple sclerosis. But we're just now beginning about the gut. We are really in the infancy stages of looking at the contents of the gut and the different kind of bacteria that they have, and there's the good and there's the bad. And I'm not sure what mononucleosis has to do with the gut. I don't know anything about that. Do you? But mononucleosis has been associated.
We have a question over here, please.
Yes, this might be a little controversial, but I'm interested in what a physician's take is on medicinal cannabis.
She's asking what the physician's take is on medicinal cannabis.
Do you hear it? Yeah, we can't hear it up here. I'm sorry.
They're both afraid to answer it. They want to know about medicinal marijuana. What are your thoughts on medicinal marijuana?
You want to take it first? Go ahead. Then I'll chime in. You want me to go first? You go first. Well, I told you I was from the mile-high city of Denver. Does that give you some idea of my experience with marijuana? And the other thing about Denver, it's only an hour's drive to Boulder, which I think is one of the pot capitals of the world, and many of my patients actually used it medicinally and for recreational uses. I think marijuana has value. It has value in decreasing pain, decreasing spasticity. There may be some help in the bladder, and I could go on and on and on. And it also has the advantage of, but I feel so good. Okay, so why don't I recommend it? I do not recommend it for MS patients. MS is a toxic disease to the brain. It damages, it destroys the brain. It's very stressful on the brain as a disease. Cannabis is very stressful on the brain as well. It's a toxin to the brain. There was a great philosopher and neurologist, maybe he was a neurologist, his name was Jerry Garcia, the Grateful Dead. I don't think he was a neurologist. But what he said about marijuana, and he had more experience than just about anybody, was pot makes you stupid. I believe him. And I'm very concerned about not only the short-term effects, because anybody's had a friend who's been on pot knows they're sort of stupid at the time, but what about the long-term effects? We don't know the long-term effects of marijuana on the brain. We know the short-term effects can make people sort of act crazy, a little stupid, but I'm very concerned about the long-term effects of cognition people on marijuana. There's some preliminary data that would support my concerns as well. I think if you've got one toxin in the brain called multiple sclerosis, you don't need to add another toxin. And we have other treatments for those symptoms that can be very effective. And I think it should not be used as recreationally, and it should only be used for very difficult to manage patients.
Okay, we only have time left for 2 questions on each side of the room. The people are already selected. So if we're not getting to you, just write down your questions, give it to me or somebody else from MS Fuse, and we'll get it turned into the doctors. They can answer it afterwards, and we'll post it online.
With primary progressive MS, an occasional relapse for less than 24 hours or 24 hours. Is there a name for this? And is there anything that can be done for this?
I think he's talking about progressive relapsing. What you're describing, Jimmy, do it? What you're describing is the name for this is progressive relapsing disease. It's a very unusual form of the disease. You have progression and relapses as well. We think that is an inflammatory, there's a major inflammatory component. Those are the patients that we think can benefit from the anti-inflammatory drugs that are currently FDA approved. And so if you're having relapses, if you're having activity in the brain by MRI, if you're having any other sorts of inflammatory activity, I believe those patients should be treated.
I have a question here.
Yes. What is the impact of chemotherapy on MS? Chemotherapy, yeah.
The effects of chemotherapy on the brain? Chemotherapy is a great anti-inflammatory component. It knocks out inflammation, and so therefore I have a number of people who've had cancer and MS, and their MS has gotten much better. We don't have specific recommendations. There are no anti-cancer therapies that are approved, FDA approved for multiple sclerosis, but I think we can see MS patients do better when they're on chemotherapy. I'm not recommending getting cancer as a treatment for MS, of course, but they tend to do better when they're on chemotherapy, although there are some exceptions. I have seen some exceptions as well.
We have to ask that everybody in the audience to please hold down the chatter, okay?
There was a drug called Novantrone, or mitoxantrone, that we used for MS. It's FDA approved for that. We don't use it anymore because it causes heart failure and it causes leukemia. So therefore, we have to be careful about using these very toxic drugs in multiple sclerosis. You want to comment?
Hi. My question was, I had a question about Lemtrada. Wasn't it supposed to get FDA approved, or at least them have an answer by the end of the year-ish?
The Lemtrada FDA decision, the deadline for that decision is November 25th. Now, the FDA may be able to delay that for a while, but I expect to hear by November 25th. They've delayed it once. They didn't approve it 6 months or so ago, and it was resubmitted, and I'm hoping to have an answer by November 25th.
And then also I wanted to ask the transition from, say, Tysabri to Lemtrada. Do you have to stay off of medication for a while until you can get onto it?
Yeah, I mean, the washout period is what we're trying to determine at this point. So for some drugs to wash out, all the older injectable medications, to wash out from those to Lemtrada is going to be very straightforward. You probably can switch right away without a washout. From Tysabri, if you go back and look at the original clinical trial of Lemtrada, when it was called Campath in those days, there were some patients who entered the clinical trial and had been on Tysabri. There were a few. We don't know what the washout is going to be. It probably has to, and it's going to depend on a number of things. How long someone's been on Tysabri, whether they're JC virus positive or negative, these are all going to be important things. And then we may have to do a washout for maybe 3 months to 6 months.
Next question.
In reference to the stem cell repair, how far does that go back? I mean, will it repair all your stem cell, or the myelin repair, I mean?
We don't know the answer to that because we're still doing the trials. But we think that the stem cells that are being made right now can get into the body, can get into the brain, and act like remyelinating cells. They take on the characteristic of remyelinating cells. That's what we know. What we don't know is how much repair is actually going to occur with those stem cells. We're optimistic that a lot of repair can take place with those. But we know we can get them into the body, we know we can get them into the brain, and we don't have the results beyond that to be conclusive. And how long it takes, that's all going to be on clinical trials.
Okay, so that's going to conclude, sorry to say, for everybody that has not had their questions answered. But actually, we have one more that came in from the internet. We had several that came in from the internet, but we don't have time for it. But this person asked for Dr. Steingo to please answer. What's the situation with Tecfidera now that there was a case of PML?
I mean, so Tecfidera has been on the market for 1.5 years. And up until this week, there were no cases of PML that were seen on Tecfidera. There is a precursor drug in Europe that they use for psoriasis called Fumiderm and related products, where some cases of PML had been seen, and 3 out of the 4 patients reported had chemotherapy. So that was part of the explanation. The Tecfidera case was reported this week. It was a patient that had been on Tecfidera for about 4 years, and the patient had chronic lymphopenia. That means that the patient's lymphocyte count was low for many years. And so we know that Tecfidera, this is a known fact, that Tecfidera can lower the lymphocyte count in some people. The FDA's recommendations on that were quite lenient. They said check it maybe annually. And so I think what all of us as practicing neurologists are going to do is check the lymphocyte count on Tecfidera on a regular basis. And if the lymphocyte count is low, then we will probably have to reconsider whether Tecfidera is the right drug. So right now there's no other risk factors. We're not changing the use of Tecfidera. We're still using it. There's no alarms. Check your blood count and check on a regular basis to make sure that you don't have a prolonged lowering of the lymphocyte count.
Okay, thank you to the doctors again.